Now coming to the antibiotics that inhibit the cell wall synthesis. Okay. Now inhibiting cell wall synthesis में कौन सी antimicrobials आती हैं? Here we have penicillins, then cephalosporins, then monobactams, then we have carbapenems. Okay. And other antibiotics. So let us see their mechanism. Now सबसे पहले bacterial cell wall समझ लो कि bacterial cell wall में होता है peptidoglycan, and this peptidoglycan contains N-acetylmuramic acid and N-acetylglucosamine, right? Then it also contains a pentapeptide unit which is attached to N-acetylmuramic acid. Now basically the enzymes that play a role in the formation of the cell wall. तो सबसे पहले होता है this N-acetylglucosamine is conversion of UDP N-acetylglucosamine to UDP N-acetylmuramic acid in presence of an enzyme which is called as enol pyruvate transferase. And this enol pyruvate transferase is an enzyme which is inhibited by phosphomycin. Okay. Then UDP N-acetylmuramic acid then acquires the pentapeptide alanine racemase, and alanine ligase helps in the formation of pentapeptide unit. So this enzyme alanine racemase and ligase, this is inhibited by the enzyme, the drug cycloserine. Okay. Then UDP is then removed from this UDP pentapeptide by bactoprenol, which is a membrane lipid carrier, and N-acetylglucosamine is added. Then these resulting molecule is then transported across the plasma membrane by bactoprenol, and then elongation of the peptidoglycan chain occurs with the help of enzyme transglycosylase. This transglycosylase is inhibited by vancomycin. Then elongation of this elongation happens by transglycosylase. Then strength to this peptidoglycan chain is provided by cross-linking, and that is done with the help of transpeptidase, right? And the drug which inhibits transpeptidase is penicillin and cephalosporin. Okay, so these are the drugs. Then another last is there is this bactoprenol. So dephosphorylation of bactoprenol results in, this is done by bacitracin. So these are the various targets in the cell wall synthesis, and these are the antibiotics which inhibit them. Now all these drugs, they are all the beta-lactams are bactericidal. They bind to a penicillin binding protein which is there on the cell membrane, and they inhibit the transpeptidase enzyme which is responsible for the cross-linking. Then bacteria which are formed without the cell wall, then they die. So this is how they act. If some bacteria which are cell wall deficient or have a structure like mycoplasma, they are resistant to beta-lactam. They are intrinsically resistant to beta-lactams, right? Now coming to the penicillin G. So what are the important points that we have to discuss about penicillin G? Naturally, what is the compound that it is obtained from? It is obtained from Penicillium chrysogenum, right? It is only the naturally occurring penicillin, while others there are a lot of semi-synthetic penicillin. Now naturally occurring penicillin hai to it was not effective orally. That is why there was a need to prepare synthetic penicillins. Then very short duration of action because it rapidly gets excreted out. Then very narrow spectrum. So narrow spectrum means it is just acting against gram-positive bacteria. And the last thing is that a lot of resistance has developed to it. Plus it also caused hypersensitivity reactions. So this is why the original naturally occurring penicillin is not used nowadays. Now the newer penicillins, what are they? So now as we know, penicillin G is not effective orally because it is gastric acid labile. So then we developed some acid resistant penicillins in which we have penicillin V, then oxacillin, then dicloxacillin, cloxacillin, amoxicillin, and ampicillin, right? So these are the various acid resistant penicillins. Then to make it long duration, benzathine and procaine added to increase to make it long acting, right? So benzathine penicillin is the longest acting penicillin. Then probenecid can be added to reduce the excretion and make it longer acting, right? After that extended spectrum penicillins were made. So in extended spectrum penicillin, the drugs that we have, let's see it on the other page. In extended spectrum penicillin, we have aminopenicillins, in which drugs that come are ampicillin and amoxicillin. Then we have carboxypenicillins, in which we have carbonicillin, ticarcillin, uridopenicillin, penicillins, in which we have methicillin, azlocillin, and piperacillin. Right, so now all these drugs all are effective against gram-negative bacteria also. Then last 5 penicillins are effective against pseudomonas also, and the last 3 penicillins are effective against Klebsiella also. So with the increase in the penicillins, there is a spectrum increase. Then resistance, how they have managed the resistance? Resistance is managed by adding beta-lactamase inhibitor. Right, so these the drug that is beta-lactamase inhibitor is clavulanic acid. Then there are penicillinase resistant penicillins, which are cloxacillin, oxacillin, nafcillin, methicillin. Right, hypersensitivity reactions, they can occur with all of them, and they are the ones which cause anaphylactic shocks also. Coming to the important pharmacokinetic parameters. Now pharmacokinetic parameters may the important things are like 1 gram of penicillin is equivalent to 1.6 million units. Right, then gastric acid breaks down penicillin, so penicillin results in decreased bioavailability. Then ampicillin and nafcillin are excreted partly in bile. Then penicillin G is given by injection IM, and it has short half-life, so it is given 6 to 12 hourly. Procaine penicillin is 12 to 24 hourly, and benzathin is the longest acting. Right, coming to the clinical uses. Now clinical uses of penicillin. So what are they? First, penicillin G is the drug of choice for syphilis. Right, benzathin penicillin is used for primary, secondary, and early latent syphilis, that is 2.4 million units intramuscular as single dose, and latent and tertiary syphilis for 3 weeks, once weekly. Right, aqueous penicillin G is drug of choice for neurosyphilis because benzathine penicillin has little entry in the brain. Then other infections that it is the drug of choice is meningococci, actinomycosis, tetanus, gas gangrene, rat bite fever, yaws, leptospirosis, streptococci, staph, endocarditis. Then also against anaerobic bacteria except bacteroids. Then there is methicillin, nafcillin, oxacillin, cloxacillin, but methicillin resistance has developed, which are called as MRSA. So in case of methicillin resistance organism, they are treated by vancomycin or teicoplanin. Okay, and if they develop vancomycin resistance, then they are treated with linezolid or streptogramins. Okay, then we have other drugs like ampicillin, amoxicillin. So like ampicillin, amoxicillin is also very effective. Ampicillin, amoxicillin, which are aminopenicillins, they are drug of choice in listeria monocytogenes and even UTI, which is caused by Enterococcus faecalis. Right, then the category is piperacillin, ticarcillin, carbanicillin, azlocillin, mezlocillin. Now they are used with beta-lactamase inhibitors and with aminoglycosides for complete coverage. And जो uridopenicillins हैं like azlocillin, mezlocillin, they are also effective against Klebsiella. So they are basically used in the ICU setup also. Okay, so इसके बाद next हम आते हैं toxicity पे. What are the various toxicities? So the first toxicity was hypersensitivity, right? Commonly associated. So intradermal sensitivity testing is developed. Then if the patient is sensitive, then all the penicillins are contraindicated except aztreonam. Okay, then ampicillin can result in maculopapular rash also in patients with viral diseases like infectious mononucleosis. Then methicillin can cause interstitial nephritis. Ampicillin causes diarrhea. Procaine penicillin results in seizures and CNS abnormalities. Oxazolidine causes hepatitis. Nafcillin causes neutropenia. So these are the various toxicities, right, of penicillins. Now coming to the next category of drugs, that is cephalosporins. The other next category of drugs that we have to discuss is cephalosporins. Now cephalosporins mein there are 5 generations. Okay, now out of these 5 generations, let's see the first generation. Now first generation mein oral cephalexin, cefadroxil, cefaridin, and parenteral mein we have cefazolin. Then second generation compounds, oral mein hai cefaclor, cefiroxim, lauracarbef, and cefprozil. Parenteral mein we have cefiroxim, cefotit, right, cefoxitin, cefmetazole, right. Then third generation compounds mein oral we have cefixim, cefpodoxim, ceftibutin, ceftitorin, cefdinir. In parenteral we have cefotaxim, ceftriaxone, ceftriaxone, ceftazidime, cefoperazone, and moxalactam. Then fourth generation में सिर्फ parenteral होती है cefepime and cefpyrome. Fifth generation is again only parenteral, and here we have ceftaroline and ceftobiprole. Okay, so these are all the drugs which are present in the cephalosporins. Now see, all drugs having A after ceph are first generation except the cefaclor. Okay, except the cefaclor, that is example cefazolin, cefadroxil. Then second generation में देखो drugs with PI in the name are fourth generation. PI, cefepime, cefepyrome, and ending with ME. So these are the fourth generation. Then drugs with rol are the fifth generation. So we have ceftarolin and ceftobipyrole, right? Drugs ending with me except the cefiroxim, they all are third generations. Third generation में all the drugs are ending with ME except the cefiroxim or 10 cephalorid, yes. Then rest of the drugs except moxalactam and cefdinir, they are all second generation compounds. So all the other drugs are second generation. Now oral or parenteral. So drugs with OR are usually oral, and drugs with, apart from these, drugs having T in the name are injectable. Anyways, this is all just a thing to help you out with remembering the names, but ultimately see, you have to remember the names. There's no shortcut to that. Coming to the pharmacokinetics part, now they are excreted via kidney through tubular secretion. Then ceftriaxone and cefoperazone, they are secreted in bile. Nephrotoxicity of these drugs is increased with loop diuretics, right? What is the spectrum of action अगर आप देखो? So the first generation compounds are effective against gram positive cocci. Okay, the second generation compounds are active against gram negative bacilli, right? Then third generation compounds are active against gram positive, gram negative cocci, bacilli, and anaerobes. In this, see, ceftazidime and cefoperazone are effective against pseudomonas also. Then the fourth generation compounds are same as third generation compound, but they are more resistant to beta-lactamases, right? Coming to their uses. Now, what are the various uses of these drugs? So, clinical uses. First generation, they are active against gram-positive cocci, staph, MRSA is resistant. Here, cefazolin is drug of choice for surgical prophylaxis, right? Then second generation में cefotatin, cefmetazole, cefoxitin, they are active against anaerobes. So cefotatin, cefmetazole, and cefoxitin, they are active against anaerobes like bacteroides, fragilis, right? Cefiroxim is used in cranial infections because it attains a good concentration in the CSF. So it is used in meningitis. Another drug that is preferred is ceftriaxone in meningitis, right? Then third generation compounds. What are coming to the third generation compounds? Now these are active against gram-negative organisms also. Then they penetrate the CSF, the blood-brain barrier also, except cefoperazone. And so all these drugs, they penetrate the blood-brain barrier except cefoperazone and cefixime. Then ceftazidime, ceftolozane, and cefoperazone. They're active against Pseudomonas. Ceftazidime is the drug of choice for melioidosis, which is caused by Burkholderia. Okay? Then ceftriaxone has maximum activity against bacteroids. Then ceftriaxone is the drug of choice for gonorrhea. Then typhoid, E. coli, Proteus, and also for meningitis, right? Then long-term use of more than 2 grams per day of ceftriaxone is associated with biliary sludging syndrome and cholelithiasis, right? Ceftriaxone also has a very long half-life, and cefotaxime is metabolized to an active metabolite, right? Then 4th generation compounds they have activity against gram-negative organisms plus Pseudomonas, which are resistant to the 3rd generation compounds. So their efficacy is almost similar. Then 5th generation compounds में आते हैं ceftaroline and ceftobipyrrole. These are 5th generation compound used in community acquired pneumonia and MRSA infections, right? These are used against MRSA and cephalosporin. Then no cephalosporin is active against Enterococci fecalis, MRSA and Listeria. Okay, Pseudomonas infection में the drug of choice is ceftazidime plus aminoglycoside. Okay, then there is a drug which is called as cefiderocol. This is a cephalosporin which is approved for complicated UTI by IV route, right? Unlike other cephalosporins, it is a siderophore, so it can go through the ion channels in the bacteria through the bacterial cell wall and effective against wide range of gram-negative bacteria. Coming to the toxicity, now what are the various toxicities that cephalosporins cause? So they cause hypersensitivity reactions. Okay, then they also cause hyperprothrombinemia, which is basically bleeding, and they cause disulfiram like reaction with alcohol, right? Then ceftazidime is also implicated in causing neutropenia. Okay, so these are the various cephalosporins. If I go on the treatment of meningitis, then empirical drug of choice is ceftriaxone. Definitive drug of choice is penicillin G. Then drug used for chemoprophylaxis is ciproflox, ceftriaxone, rifampicin. Then drug of choice for mass chemoprophylaxis is ciproflox, rifampicin. And most effective drug choice for chemoprophylaxis is ceftriaxone. Okay, so this is one most effective drug for chemoprophylaxis: ciprofloxacin, ceftriaxone, rifampicin. For mass chemoprophylaxis, we have ciprofloxacin and rifampicin. Coming to other beta-lactams, in this we have monobactams. This group includes Astriona, active against beta-lactamase producing Pseudomonas. It is used in patients with a severe allergy to penicillins or cephalosporins. Okay, then we have carbapenem. Carbapenem में हमारे पास drugs आती हैं imipenem, doripenem, meropenem, ferropenem, and ertapenem. They have wide spectrum of activity. Now these are beta-lactamase resistant drug of choice in Enterobacter, Klebsiella, and Acinetobacter. These are the only beta-lactams effective against extended spectrum beta-lactamase producing organisms, and so they are drug of choice in these ESBL producing bacteria. Now imipenem is inactivated by renal dehydrogenase 1, so it is combined with cilastatin, which is an inhibitor of renal dehydrogenase 1. Okay, so this cilastatin increases the half-life of imipenem and inhibits the formation of the nephrotoxic. So this combination imipenem plus cilastatin is used. इसका adverse effect एक होता है that it causes seizures and GI distress. Okay, now other penems are not metabolized by renal dehydrogenase inhibitor, and ertapenem is very long acting. Okay, then there is a new drug in this category that is called as loracarbev. Loracarbev. This is chemically similar to cefaclor. It is given orally, and overdose can cause seizures. Then other drugs like beta-lactamase inhibitors. Now beta-lactamase inhibitors may we have clavulanic acid, sulbactam, tazobactam, and avibactam. Right? These are more active against plasmid encoded beta-lactamase. Then amoxicillin combined with clavulanic acid, ampicillin combined with sulbactam, piperacillin is combined with tazobactam. Okay. Now there's another combination. Ceftazidime is combined with avibactam. It is approved for complicated UTI, pyelonephritis वगैरह ना, pyelonephritis. Then meropenem velorbactam is a new combination which is used for complicated UTI, and relibactam is approved for the treatment of intra-abdominal infections. This is used in combination with imipenem plus cilastatin. Right? Then the other category of drugs that is called as extended spectrum beta-lactamase, ESBL. Now these are the enzymes that confer resistance to most of the beta-lactam antibiotics. They are found exclusively in gram-negative bacteria, especially Klebsiella and E. coli. Right? They can be inhibited by clavulanic acid or tazobactam. They cannot hydrolyze carbapenems. Carbapenems are drug of choice for treatment of infections caused by ESBL. Okay. Then what are the other cell wall synthesis inhibitors? इसमें आता है glycopeptides. इसमें आती है vancomycin. This inhibits the transglycosylase. Right? So vancomycin is narrow spectrum, active against gram positive, including MRSA, SA, penicillin resistant, and Clostridium difficile also. So it is the drug of choice in MRSA infections, Corynebacterium jejuni, and penicillin allergic patients. Then another drug that is we study is teicoplanin. Another glycopeptide given once daily due to long half-life. It is administered parenterally IV and can be given by IM route also, and is excreted and changed in the urine. Now another very important thing is rapid IV injection of vancomycin causes red man syndrome. That is basically flushing due to histamine release. Okay, this is the most common adverse reaction. So it is the most common adverse reaction. Then other थोड़े बहुत करते हैं. Vancomycin is used orally to treat pseudomembranous enterocolitis caused by Clostridium difficile, because it is not absorbed orally, and so it acts at the local high concentration reaches the colon. Then vancomycin resistance can develop. I have told you vancomycin resistant Staph aureus, VRSA are there. Then they are treated by linezolid or streptogramins. Then there is a new drug, oritavancin. It's a newer glycopeptide which is used for the treatment of MRSA infections. Then telavancin is approved for complicated skin infections. And another drug is there, dalbavancin. This is used once weekly. Then the last drug that we have to do is in this category is phosphomycin. This inhibits the cell wall synthesis by inhibiting the enol pyruvate transferase. इसके यूज से डायरिया होता है. It is the drug of choice with nitrofurantoin for uncomplicated UTI. Okay. Then another drug is bacitracin. This also inhibits and causes marked nephrotoxicity. It is used only topically. Then cycloserine. This inhibits the cell wall synthesis. It has potential neurotoxic effects also, and causes neuropsychiatric symptoms. It is the second line drug for treatment of tuberculosis, cycloserine. So with this we finish the drugs which are basically cell wall synthesis inhibitors. Next we'll see the drugs which are protein synthesis inhibitors. Now let us study about the drugs affecting the or inhibiting the protein synthesis. Right? Now drugs inhibiting the protein synthesis. So let us see the classification of these drugs. So इसमें ना देखो सबसे पहला जो ऑप्शन हम पढ़ेंगे that is tetracyclines and glycylcyclines. Now ये जो होते हैं, see they bind on the 30S ribosomal unit and they inhibit the amino acyl tRNA attachment. Okay. Second is chloramphenicol, and this binds to the 50S ribosome and it inhibits the peptidyl transferase. Okay. Next is Macrolides, Lincosamides and Streptogramins. They inhibit the 50S ribosome and they inhibit the translocation of peptide chain. Right. Fourth, linezolid, 23S fraction of 50S ribosome. They inhibit the initiation. Fifth is aminoglycosides. So 30S and 50S subunits. They cause freezing of initiation, interference with polysomes formation and misreading of mRNA code. Right? So these are the drugs which inhibit the protein synthesis. Now all these drugs are bacteriostatic except aminoglycosides and streptogramins. These are the drugs which are bactericidal. Okay. So this is an important point that you have to remember. Again, another type of classification is there, that is broad spectrum. इसमें आते हैं chloramphenicol and tetracyclines. Then drugs having moderate spectrum, they are macrolides and ketolides, and drugs having narrow spectrum, they are lincosamides, streptogramins and oxazolidinone. Right? So this is about the classification. Now let us see chloramphenicol first. Now chloramphenicol, it basically inhibits the peptidyl transferase. It undergoes intrahepatic circulation. Right? It is a bacteriostatic drug. It is the drug of choice in typhoid fever, but due to development of resistance, now the drug which we use are ceftriaxone. Right? It is also active against anaerobes. Now it can result in superinfection because of its broad spectrum. Then it causes dose dependent bone marrow suppression and irreversible myelosuppression. Right? Another side effect that happens is gray baby syndrome, which is characterized by decreased RBCs, cyanosis and cardiovascular collapse. So these are the important points about chloramphenicol. Next, we come to tetracyclines. Now these tetracyclines, they bind to the 30S ribosomal subunit and they inhibit the binding of aminoacyl tRNA, right? It is classified as group 1, which consists of tetracycline, chlortetracycline and oxytetracycline. Then group 2, which consists of demeclocycline and limicycline. Then group 3, which consists of doxycycline, minocycline. Then group 4, which consists of iravacycline and omadacycline and saracycline, right? So these are the various tetracyclines that we have. Coming to the pharmacokinetics. Now pharmacokinetics mein usually oral absorption is impaired by food and multivalent cations, right? Then tetracycline crosses the placenta and affects the fetus. Next, it undergoes enterohepatic circulation, right? Then they are excreted in urine except doxycycline. So doxy is basically excreted in the feces and it can be used in renal failure patients. Then half-life is longer than half-life of doxy and mino is longer than other tetracyclines, right? Coming to the uses. Now what are the various uses? Tetracyclines, सबसे पहले they develop resistance due to efflux pumps. Then it is the first choice drug in lymphogranuloma venereum, granuloma inguinale, then atypical pneumonia, cholera, brucellosis, plague prophylaxis, relapsing fever, Lyme's disease, rickettsia and chlamydia. Okay. Other uses include, what are the other uses? Meningococcal carrier state, इसमें आती है minocycline. Then malaria prophylaxis, इसमें आती है doxycycline. Then amoebiasis, इसमें आती है doxycycline. Then syndrome of inappropriate idiot secretion में we use demeclocycline. Then it is used for pleurodesmosis in pleural effusion due to cancer. Then it is used in leprosy. Minocycline is used in leprosy. Then peptic ulcer is used tetracycline. Okay. Then what are the coming to the new tetracycline? So if we come to the new tetracyclines, इसमें आती है iravacycline IV. It is used in complicated intra-abdominal infections. Then omadacycline is used oral or IV in complicated acquired pneumonia. Then saracycline is used orally in inflammatory lesions of non-nodular acne, right? So these can be various drugs, new drugs that can be used. Coming to the toxicities of tetracyclines. Now the first toxicity is that it can result in superinfection, diarrhea, and it can result in superinfection and diarrhea and pseudo membranous enterocolitis, right? Then it is contraindicated in pregnancy because it affects the teeth and bones of the fetus. Then if you give it, contraindicated in children. Contraindicated in children less than 8 years because it can result in dentition problems. Then it can result in hepatic necrosis outdated tetracyclines can result in a syndrome which is called as Fanconi syndrome. Okay, then tetracyclines can exacerbate the renal dysfunction. Then demeclocycline and oxycycline can result in photosensitivity. Then minocycline may lead to vestibular toxicity. Diabetes insipidus may be precipitated by ADH, antagonistic action of demeclocycline, right? Then there's a new drug. It is called as tigecycline. This tigecycline, it belongs to a new group that is basically called as glycyl cyclines, right? Now, this tigecycline, mainly it is used in serious, complicated skin and skin structure infections, right? It has a broad spectrum, including MRSA, VRSA, etc. It is ineffective against Proteus and Pseudomonas. Tigecycline is administered intravenously. Then it is mainly excreted in bile, so no dose requirement is there. Okay. Now एक important aspect होता है STDs का, that is sexually transmitted disease. Now these sexually transmitted disease को एक बार देख लेते हैं. तो जैसे है, सबसे पहले है urethral discharge. The organism is Neisseria gonorrhoeae. The color is grey, and the color of the discharge is grey, and the tablet which we use is azithromycin or tablet cefixime, right? Then we have vaginitis. Causative organism is Trichomonas gardnerella. The discharge is green. The tablet used is secnidazole, right? Then there is genital ulcer. This is usually caused by syphilis, called as chancroids. The discharge is white, and the treatment here is injection benzathine penicillin. Then we have genital ulcers, non-herpetic due to allergic to penicillin. So here again, if it is syphilis and chancroid, but the discharge is blue in color, then the drug of choice is tablet doxycycline or tablet azithromycin. Then genital ulcer, herpetic, right? It is caused by herpes simplex. The discharge is red, and the tablet is acyclovir. Okay. Then we have lower abdominal pain. Organism is Neisseria gonorrhoeae, Chlamydia trachomatis. The discharge is yellow, and tablet is cefixime, right? Then inguinal bubo, caused by lymphogranuloma venereum. The discharge is black, and the organism is the drug that is given is tablet doxycycline. So this was about tetracyclines and doxycyclines. Coming next to other categories, we have macrolides. Now in macrolides, these are the drugs in which we have erythromycin, azithromycin. So the drugs are erythromycin, azithromycin, roxithromycin, clarithromycin, right? There's another immunosuppressant drug, that is tacrolimus. This is also a macrolide antibiotic. This binds to 50S ribosome and blocks the translocation of peptide chain, right? Pharmacokinetics में हम आते हैं. So this basically is taken orally, and it is excreted by biliary route, right? Excretion of azithromycin is slow. Uses अगर हम बात करें तो macrolides are used in सबसे पहले chancroid by Haemophilus duceli. इसमें azithromycin single dose, right? Then Corynebacterium, diphtheria, Legionella, atypical pneumonia, and whooping cough, right? So these are the indications of using macrolides. It can be also used for diphtheria and infection caused by chlamydia. Okay, a single dose of azithromycin is effective in the infection caused by chlamydia. Next there is a drug called as clarithromycin. It is approved for prophylaxis and treatment of Mycobacterium avium complex, right? And also in the treatment of H. pylori peptic ulcer, right? Then macrolides, they also have anti-inflammatory action. They are used in prevention of cystic fibrosis exacerbation, right? Next we have spiramycin. This is the drug of choice for toxoplasmosis in pregnancy, right? Then there is a drug fidaxomicin. This is used in the treatment of Clostridium difficile infection, right? So these are some clinical uses of azithromycin and clarithromycin. Coming to the toxicity part. So what are the toxicities? First, it can cause diarrhea by stimulation of motilin receptors. Then second है erythromycin estolate is implicated in the causation of acute cholestatic hepatitis. Third, it can be used in infantile hypertrophic pyloric stenosis, right? Then fourth है azithromycin. Usually these drugs, erythromycin and other drugs also, they inhibit CYP3A4. So if it is given to patient who is taking, if it is given to patient who is taking terfenadine and astimazole, then it can result in arrhythmias, long QT, prolongation of QT interval, right? Now in this, azithromycin is not an inhibitor. Okay. Next, IV erythromycin can cause dose-dependent ototoxicity. Okay, and erythromycin can also increase the plasma concentration of theophylline. Okay, so with this we complete the macrolides. The next drug that we take is ketolide. Ketolides mein the drug that we have is telithromycin. This is basically excreted in bile and is an inhibitor of CYP3A4. Then we have lincosamide. Okay, now in lincosamide, this group includes clindamycin and lincomycin, right? The main use is in against anaerobes like bacteroids and propionibacterium. It is also the drug of choice for treatment of severe invasive group A streptococci, right? Also used in pneumocystis jirovecii and toxoplasma gondii. It is used as an alternative to amoxicillin or ampicillin for prophylaxis against endocarditis following dental procedures, right? It is the most common antibiotic implicated in causing pseudo membranous enterocolitis, right? Next category of drugs that we have is streptogramins. Coming to the streptogramins. Now these basically streptogramins are bactericidal. Okay, now they इसमें जो हमारे पास drug है वो है quinopristine and dalfopristine. It is a bactericidal combination of two streptogramins. Now this combination is effective against gram-positive bacteria. It is effective against penicillin-resistant pneumococci, methicillin-resistant Enterococcus faecalis, MRSA, and also VRSA. So it is also effective against Legionella and Mycoplasma. Okay, these drugs are potent inhibitors of CYP3A4, so a lot of interactions are possible. Then venous irritation is a very common side effect. Other adverse effect will include arthralgia, myalgia syndrome. Okay, then the other category of drugs that we have is Oxazolidinones. Now Oxazolidinones, they include the drugs linezolid, and tadizolid. They bind to the 23 as part of 50S ribosomal unit. Now these are active against MRSA, VRSA, and vancomycin resistant Enterococcus faecalis as well as. The major adverse effect of these drugs is thrombocytopenia or neutropenia, right? And these drugs, they also have a MAO inhibitory action, so they can also cause serotonin syndrome. Okay. Next, the category of drugs that we have under protein synthesis inhibitors is aminoglycosides, which is a very big group of drugs, and these drugs include streptomycin, gentamicin, then kanamycin, tobramycin, amikacin, cisomycin, netilmycin, neomycin, and flamicetin. They exhibit concentration dependent killing and also have a post antibiotic effect. Okay? So they are used as single daily dose also. Now these drugs are bactericidal inhibitors. Okay, they are inactive against anaerobes because they penetrate the bacteria cell wall through a oxygen dependent transport system, right? They bind to 30S and 50S ribosomal subunit, 30S and 50S, and they inhibit the freeze initiation and cause misreading of mRNA code. Now these drugs are not absorbed orally, okay, and they do not cross the blood-brain barrier. They are excreted by glomerular filtration. Resistance develops to these drugs due to formation of inactivating enzymes, right? Now what are the uses? So what are the uses of glycosides, aminoglycosides? So gentamicin, tobramycin, and amikacin, they're effective against gram-negative organisms including Pseudomonas, right? Then streptomycin is the first line drug for treatment of tuberculosis, plague, and tularemia. Amikacin is second line drug for treatment of MDR TB. Okay. Then neomycin and flamicetin used topically only because they are very toxic. Then neomycin can be used in gut sterilization, in hepatic encephalopathy. Okay. Next है spectinomycin. It is used as a single dose treatment for penicillinase producing Neisseria gonorrhoeae. Right. Coming to the toxicity. What are the toxicities? So they cause ototoxicity, that is damage to the hair cells, and it occurs when it is being used for a long duration. Now this ototoxicity is usually irreversible also. Then there is nephrotoxicity. It is almost always irreversible. Okay? And the third thing is neuromuscular blockade. Now this is usually rare, but it can result in severe respiratory depression. Okay? Then intravitreal injection of gentamicin can result in macular infarction. Then there is a drug which is called as plazomicin. This is a new drug, recently approved aminoglycoside. ठीक है? Other drugs which are inhibitors of protein synthesis. इसमें एक आती है Plurimutilin. इसके अंदर ड्रग का नाम है retapamulin. This is a new drug for the topical treatment of impetigo due to methicillin sensitive staph aureus. ठीक है? Another drug is lefamulin. This is a new drug which is used for community acquired pneumonia. Then there is mupirocin. Now this mupirocin is used topically or nasally for staph infection, right? Then fusidic acid. Now this fusidic acid is again used topically for staph infections. Okay? The next category of drugs that we discuss is antimetabolites. Coming to the antimetabolites. Now these are the drugs which basically inhibit the endogenous metabolic pathways. The most common pathway that is inhibited is folic acid synthesis, right? Now what are the drugs which fall in this category? I'll show you with the mechanism that there is PABA plus glutamate plus pteridine. Now these things, they together form dihydrofolic acid, and this is formed by an enzyme, folic acid synthase. Okay, and the drugs which inhibit this enzyme are sulfonamides, PAS and dapsone. Okay, then dihydrofolic acid is finally converted into tetrahydrofolic acid. Okay, this is basically mediated by the enzyme dihydrofolate reductase. Okay, and what are the drugs which act at this place? They are trimethoprim, pyrimethymine, proguanyl and methotrexate, right? So this tetrahydrofolic acid is there. This is then incorporated in the DNA and further reactions. So the drugs which we are talking about are sulfonamides, PAS, dapsone, which inhibit the folic acid synthase, and trimethoprim, pyrimethymine, proguanyl, methotrexate, which inhibit the dihydrofolate reductase. So these are the two systems. Then there is one more drug, that is ethambutol, which inhibits arabinogalactan synthesis and incorporation of mycolic acid in the cell wall of mycobacteria. So this ethambutol is basically used in the TB treatment. So this is another drug which also is a metabolic inhibitor. Now coming to the characteristics of antimetabolites. So characteristics mein dekho, let's see the sulfonamides first. So sulfonamides are first of all bacteriostatic agents, right? Then selective toxicity to bacteria is there, because mammalian cells, they do not synthesize folic acid and they utilize the preformed folic acid. Then they are not effective in pus, as pus has large amount of PABA. Okay? Then these drugs, they are metabolized by acetylation, and as we have earlier also drawn, the drugs undergoing acetylation are sulfonamides that include dapsone, hydrolazine, isoniazid and procainamide. Okay. Next, again the solubility decreases in acidic urine, and so it causes crystal urea in urine. This is minimum with sulfasoxazole. Then sulfadoxin is longest acting and sulfacitin is shortest acting, right? If we see the classification, then systemic use as oral agents. So what are the drugs which are used? Now in this we have short acting, we have intermediate acting and we have long acting. So short acting mein we have sulfasoxazole, sulfamethisole, right? Intermediate acting is sulfamethoxazole, sulfadiazine, and long acting it is sulfadoxin, right? Then for use in GIT, topical use in GIT, we have sulfasalazine, and for topical use we have silver sulfadiazine, sulfacetamide, right? Next we have drugs in clinical uses. What are the uses of these drugs? Now in this sulfacetamide is used in ocular infections, right? Mephenide and silver sulfadiazine, they're used in burn patients as topical. Then sulfadiazine is used for nocardiosis, and sulfasoxazole is used for UTI. Then sulfasalazine and all-salazine is used for treatment of ulcerative colitis, right? Coming to more uses, sulfadoxin is combined with pyrimethymine, used for malaria. Then sulfadiazine and pyrimethamine, also used for treatment of toxoplasmosis and prophylaxis of pneumocystis jirovecii pneumonia. Then sulfadiazine is used for fungal keratomycosis. Okay, coming to the toxicity. In this, skin rash can happen, as it is a skin rash can happen because of the hypersensitivity. Okay, they cause granulocytopenia, thrombocytopenia, and aplastic anemia. They can cause acute hemolysis in patients with G6PD deficiency. They precipitate urine and cause crystalluria. Then they displace bilirubin from plasma protein binding and cause kernicterus, okay, in newborn, right? Then the other drug that we normally combine with sulfonamides is trimethoprim. Now trimethoprim is a bacteriostatic agent. It inhibits dihydrofolate reductase. Okay, it attains high concentration in prostate and vaginal fluids. Then it is usually combined with sulfonamides and alone used in UTI and prostatitis. It causes megaloblastic anemia, causes hyperkalemia, right? So what is the combination that we are talking about? That is cotrimoxazole. This is basically a fixed dose combination of sulfamethoxazole and trimethoprim in the ratio of 5:1. Okay, this combination is bactericidal. Then this bactericidal activity is due to a sequential blockade. Okay, when you give FDC in the ratio 5:1, then plasma concentration becomes 20:1. Okay, then because of the difference in the bioavailability and the volume of distribution. Now this cotrimoxazole is effective in UTI, respiratory tract infections, MRSA, and it is the drug of choice for pneumocystis, nocardiosis, and infections which are caused by Burkholderia cepacia. Right? So these are the important details related to cotrimoxazole. Next we come to the drugs which inhibit the nucleic acids, that is fluoroquinolones. The next category of drugs that we have to discuss are the drugs which inhibit the DNA, right? Now in this, the drugs that we have is fluoroquinolones. Now fluoroquinolones, they inhibit the DNA gyrase enzyme. Now this DNA gyrase, it basically nicks the double-stranded DNA and introduces negative supercoils and then reseals the nicked ends, right? So these are fluoroquinolones, including nalidixic acid and novobiocin. Then another category of drugs which inhibit the DNA is rifampicin. So rifampicin, it basically inhibits the transcription by inhibiting the DNA dependent RNA polymerase. Then another drug which also inhibits the DNA is metronidazole. So metronidazole क्या करता है? It basically generates reactive nitro radicals. इसमें then nitrofurantoin is also considered to be acting by destruction. Then we have various antiviral agents also, which are basically nucleoside analog that will complete in the antivirals. Okay. Now coming to the fluoroquinolones. So fluoroquinolones में the drugs which we study are ciprofloxacin. I'll write one name complete. Ciprofloxacin, then norfloxacin, then lomifloxacin, then ofloxacin, then levofloxacin, then gatifloxacin, payfloxacin, sparfloxacin, moxifloxacin, flerofloxacin, geranofloxacin, gemifloxacin, delafloxacin, and trovafloxacin. Okay. These drugs, they have got a good, have got a long post-antibiotic effect also. They have good oral bioavailability, and they have Norflox has minimum bioavailability, and Levoflox has maximum bioavailability. Then these drugs, Sparfloxacin, Moxifloxacin, and Trovafloxacin, they have got long half-lives also, and they can be administered once daily, right? Then if we come to the uses, now what are the uses? Uses may they have good activity against Pseudomonas, right? Then Ciproflox is the drug of choice for prophylaxis and treatment of anthrax, also used for prophylaxis of meningococcal meningitis. Okay. Then Ciproflox and Levoflox are used against Pseudomonas. Levoflox, Gatti, Gemi, and Moxie, they are also called as respiratory fluoroquinolones due to their enhanced activity against chlamydia, Legionella, Mycoplasma. These are the things. Then fluoroquinolones are also effective in TB, and they can be used in prophylaxis of neutropenic patients, right? Treponema pallidum and Nocardia, they are resistant to all fluoroquinolones. Okay, आगे बढ़ते हैं. Coming to the toxicity, GI distress करते हैं. Then another problem that they cause is cartilage problem. So they are not children 18 years old, not used in these children. Then tendinitis is seen, phototoxicity is seen, right? This is maximum with lomifloxacin and sparfloxacin. Then spar and Gatti prolong the QT interval, right? Trova causes liver toxicity. Then it is seen that they increase the concentration of theophylline. So this is their drug interaction, which is caused by the floxacins. NSAIDs increase the toxicity of these drugs, and that is CNS toxicity, मतलब वो seizures precipitate करते हैं. Many are withdrawn from the market, like temafloxacin, trovafloxacin, grepafloxacin, and clinafloxacin, right? Then abhi fluoroquinolones, again they cause peripheral neuropathy, right? So these drugs have been FDA has issued warning also. Okay, next है urinary antiseptics. Urinary antiseptics are the oral drugs, and they suppress the bacterial growth. They are more effective in acidic urine because low pH is an independent inhibitor of bacterial growth. The important urinary antiseptics are nitrofurantoin, methenamine, and nalidixic acid. Okay. Now, nitrofurantoin, these drugs, they are basically used in urinary infections like Pseudomonas, except Pseudomonas and Proteus. Now they are very infrequently used because we have got better agents also. Methenamine क्या करता है? It releases formaldehyde, right? Which is the major formaldehyde which causes the antibacterial acid activity. Then nalidixic acid is basically a quinolone. Okay, and the main adverse effect is neurotoxicity. Okay, then next we have drugs affecting the cell membrane. Okay, so let us see on the other page the drugs which affect the cell membrane. Now, what are the drugs which affect the cell membrane? So in this we have polypeptide, in which we have polymyxin B, colistin, tyrothricin. Then we have polyene antibiotics, in which we have amphotericin B and nystatin, natamycin, and hamicin. And we also have drugs azoles, which are basically antifungal agents, ketoconazole and fluconazole and itraconazole, right? So these are the drugs. Then there is a drug which is called as daptomycin. Now daptomycin is basically a lipopeptide. This also causes depolarization of cell membrane by potassium efflux and cell death, right? Then it is now drug of choice for VRSA. It is also effective in organisms which are resistant to linezolid and streptogramins. Okay, the toxicity caused by these is myopathy, right? Then another pulmonary surfactants, they antagonize daptomycin. Okay, next we have polypeptide antibiotics. Now polypeptide antibiotics include polymyxin B, bacitracin, colistin, and tyrothricin. Now all these except bacitracin, they affect the cell membrane. Bacitracin is the only drug which inhibits the cell wall. Rest all inhibit the cell membrane. Okay, so with this we complete the general considerations of antimicrobials. Now we have to start with the, so not general but non-specific antimicrobials यहाँ पे खत्म होते हैं. Now we start with the specific antimicrobials which are active against, so in this we have TB, malaria, antifungal, antiviral, anti-helminthic, anti-protozoal, right, and anti-leprosy also. So these are the topics which are remaining, which I hope to complete them. I'll record all of them and complete them in one go. Okay.